Dear ladies and gentlemen, today we shall speak about mastering the art of non-contact navigated laser retinopexy, essential tips for everyday practice. My name is Oleg Parkhomenko. I'm the doctor ophthalmologist from Ukraine. I work in the biggest network of private clinics in Ukraine with 9 branches all over Ukraine, having 2 navigated laser system, Navilas. Before the beginning of full-scale invasion of Russia to Ukraine, we planned to buy 1 more, but the war messed up our plans. The popularity of Navilas is connected with revolutionary properties of navigated laser system. Among them are unprecedented safety, accuracy, and efficacy. The new and unique property, which we shall talk today about, is non-contact treatment of periphery of retina. This feature became possible because of an active tracking, which allows to perform laser peripheral retinal retinopexy regardless of eye movements and blinking. We use actively the system of remote planning for doctors working in all branches of our clinics for teaching purposes. We make live laser surgeries in Messenger, Viber, for example, with the help of app iFast Viewer. That helps to educate personnel to prescribe non-contact laser procedures more confident, as the clinician can assure that procedure is rather simple, quick, and excellently tolerated by the patient. The system of remote planning also helped us to engage very fast new doctors in the process of laser treatment, which had no or limited experience of working in macular region, for example, with microimpulse regimen in diabetic macular edema, or in central serous chororetinopathy, or performing laser in some rare cases such as EELS or COS or von Hippel-Lindau disease, etc. Working in the capital of Ukraine, I can control the proper planning and delivering of laser treatment, which is performed in the other clinic in Odessa, with approximately 500 kilometers far from Kiev. We also have a teaching center, which is used to educate the doctors from our network of clinics and the practical courses for young doctors from all over Ukraine to master peripheral laser retinopexy or panretinal laser coagulation. We use the program Navigate by ODOS to teach the doctors with the patterns of laser coagulate placement, their size and other parameters which look obvious for experienced practitioners but must be clarified in different clinical cases for beginners. Today, we perform up to 80% of peripheral retinopexy in non-contact manner. The exclusion are the patient with extremely sensitivity to light flashes, blepharospasm, or when the extensive treatment is planned with the need of application of more than 500 coagulates, which can make the patient fatigued. Up to our experience, up to 200 coagulates is well tolerated by majority of our patients easily. The quantity of more than 300 can be a little uncomfortable. The quantity of more than 500 can make the treatment uncomfortable for the patient. So in those cases, we prefer to make retinopexy with a contact lens. The efficacy of treatment in complex cases, such as local retinal detachments or horseshoe tears with vitreous hemorrhages, doesn't depend on contact or non-contact procedure. The non-contact procedure allows us to be more flexible. For example, we can avoid some corneal opacities or lens opacities and perform the treatment properly with good visualization. We perform the comparison of visual field of non-contact objective and pan-fundus contact lenses such as PRP by ocular or HR wide field by walk. The visual field in most cases is equivalent or even better with non-contact objective. But with a contact lens, one has to make a little lateral compression to reach the far periphery, which is easily accessible with non-contact objective without any pressure to the eye globe and connected with the discomfort for the patient. Treatment in an infrared lighting of fundus makes the process of treatment even much more comfortable for the patient because of the absence of bright light, of background illumination, like in the slit lamp mounted lasers. In our experience, performing the laser in upper or lower quadrants can be the most challenging. Before performing of laser, we propose to draw the scheme of fundus, of peripheral degenerations and tears in order not to forget any lesions while lasering. According to the article of Lin and co-authors, the number of detections of retinal tears in lower quadrants is the lowest. While working in the lower and upper quadrants, we propose to use topical anesthesia, eye drops in both eyes before the treatment, and to fix the eyelid with doctor's fingers to perform the treatment promptly. If we use a treatment plan of less than 100 Bogomolets, the topical anesthesia may not be necessary. We use a bolster or a kind of overlay to increase the distance between forehead of the patient and non-contact objective. This allows the upper quadrants of fundus to be easily accessible. Before performing of laser in non-contact regimen, we propose to use teaching mode of Navilas. You can make a photo of peripheral fundus of your colleagues in inactivated laser mode and plan virtual treatment on retinal periphery. Also, it is very useful to practice of making high-quality pictures of fundus periphery of your patients with non-contact objective. This will increase compliance and understanding the problem and pathology by the patient. For the doctor, it will be a good training for capturing and visualization of pathology. Also, it will reduce the time for further planning as you will have a high-quality photo and only need to plan the treatment. Also, you can make this plan beforehand while making the photo and explaining the patient the aim of the treatment. Thus, when you will perform the treatment, the time for planning will be saved. Here, you can see the fogging of non-contact lens because of the patient's breath. The fogging of non-contact objective can significantly complicate the treatment process and reduce the quality of image. Here is an example of anti-fogging spray we use in daily practice. We propose to have a microfiber cloth for lenses somewhere near at hand in order to use it at any time during treatment process. After using of anti-fogging spray, you can see that unfogging is going about 10 times faster than before, so it can make the process of treatment much more comfortable and quicker.
In this video, we present a clinical case of non-contact navigated laser coagulation in patient with peripheral retinal tear, central corneal opacity, corneal edema, and endothelial dystrophy. Phacoemulsification with subsequent keratotransplantation were planned. Shameflu corneal tomography shows significant anterior and posterior corneal irregularities and also areas of corneal thinning and thickening. An OCT shows marked changes of epithelium, endothelium, and corneal stroma. The whole treatment process was performed under the circumstances of infrared fundus lighting. We used non-contact objective to make a fundus photo, then planned further treatment with 3 rows of practically confluent laser spots. Then we focused on the zone of peripheral changes bypassing corneal opacity. After applying of several test burns, fundus photo was made to determine sufficiency of laser power. Then the treatment proceeded on the selected parameters. Maximal mydriasis and eye moistening were crucial. Due to possibility of preplanned navigation treatment, laser machine tracks the eye movement and blinking, stopping the treatment automatically when needed. Color fundus, which was used during planning procedure, is automatically overlaid over live infrared peripheral retina image and must be approved by retina practitioner during treatment to deliver laser to appropriate area and to assure safety. As the treatment is done under the infrared light, at the end of procedure the color image was acquired to prove the sufficiency of treatment. Overlaid animation demonstrates retina whitening in place of laser application. Detailed report is prepared at the end of treatment procedure to document applied treatment energies and patterns. Indirect ophthalmoscopy performed 2 weeks after laser reveals the row of confluent pigmented coagulates.
Here is a clinical example of patient with artifacia, vitreous hemorrhage, and symptomatical retinal tear. You can see a horseshoe tear. The caution zones are placed on the disc and macular region. As it is the upper quadrant treated, the bolster is already engaged. After placement of the caution zones, the treatment is performed. We fixate with the fingers the upper eyelid, but allow the patient to blink in order the procedure to be comfortable. Because of the yellow wavelengths of the laser, you can see that laser coagulates are slightly white. The degree of laser coagulate is about 2 according to Latino classification. The second part of the plan is made to encircle the retinal tear. Here you can see that the outer edge of retinal tear is pretty accessible. As for example, it can be a problem for conventional laser while using a Goldman type lens. We ask the patient to blink several times to maintain corneal transparent to acquire good visualization. Here is a retinal tear immediately after the treatment. Here is a retinal tear immediately after the treatment. Here you can see the status of retina 2 weeks after peripheral laser retinopexy of horseshoe tear. You can see that the coagulates are well pigmented. Here you can see a clinical case of non-contact peripheral retinopexy in symptomatic horseshoe tear. We use infrared lighting to make the treatment process more comfortable for the patient. Now we titrate the power. A little bit increase in laser power to achieve the adequate laser coagulates. Here we use a 30 milliseconds pulse duration. We allow to blink several times for the patient to maintain the cornea transparent. And we reduced the laser power to the end of the procedure to make it really comfortable. After the procedure, we receive a report, objective report of the treatment delivered. You see the whitening of the retina near the retinal tear. Here is a case of operculated retinal tear with a local retinal detachment in the far periphery, in the upper quadrant. In those cases, it is advisable to fixate the upper eyelid of the patient with a finger. But as the quantity of the coagulates is not very high, the anesthetic mustn't be applied obligatory. So here is a report of performed treatment. Here you can see an interesting case of retinal detachment few days after phacoemulsification surgery. It was a trauma case, and as the cornea became transparent and the patient had 20/20 vision on the third day after the surgery, the retinal detachment was revealed. As we cannot perform the laser with contact lens, we prefer to make a non-contact treatment with Navilas Laser System. On the left, you can see maybe the laser scars or the result of subretinal hemorrhage, which was during the trauma.
Помогайте. Хорошо.
The laser is applied across the border of detachment of neurosensory retina. You see a slight blanching of retina adjacent to the retinal detachment.
Спасибо.
We use additional plans while treating this patient in order to achieve the confluent laser scar after the treatment. We inspect this patient more than 1 year after this treatment, and the retina is attached closer to the center. So the laser works properly. This is an additional plan to make the line of a confluent laser enough to fixate the detached retina. Here you can see a report immediately after the treatment, and here you can see the picture 2 weeks later after the treatment. Here you can see few complex cases, non-contact laser retinopexy and narrow pupil with posterior synechia and progressing retinoschisis before phacoemulsification. The laser was performed earlier in the other clinic but failed to stop the progression of retinoschisis. In such a case of narrow pupil and cataract, the performing of laser retinopexy is complicated on any laser system, but easily performed on non-contact Navilas. You see the planning and the report made immediately after the treatment. Here you can see the fundus immediately after the treatment, with a slight blanching of the adjacent retina. Here is a clinical case of horseshoe tear with the retinal detachment successfully treated with non-contact objective. Here is a clinical case of lattice degeneration with tears successfully treated with non-contact objective. Here is a clinical case of lattice degeneration with tears and macular on symptomatic retinal detachment successfully treated with non-contact objective. 1 year later, the traction and retinal detachment spontaneously regressed with increase of field of vision. Thank you for your attention.